a 53-year-old woman with sudden onset of double vision. Case report. A 53-year-old woman presented with sudden onset of double vision and was admitted to this hospital. Her medical history was unremarkable except for hypertension, and at 16 she had had pyelonephritis. Her father died of gastric carcinoma when he was 48. On admission, the patient's blood pressure was 180 over 100 millimeters of mercury. Neurological examination showed somnolence, bilateral ptosis, complete right oculomotor nerve palsy, monocular downbeat nystagmus of the left eye, impairment of both adduction and upward movement of the left eye, left hemiparesis, and bilateral ataxia. Monocular downbeat nystagmus was present in the left eye regardless of the gaze of the eye. Laboratory examination revealed hyperlipidemia, and echocardiography showed left ventricular hypertrophy. Computed tomography, CT, and magnetic resonance imaging, MRI, disclosed infarction in the right midbrain and in the thalamus. Right vertebral angiography indicated no venous abnormality. Diagnosis and therapeutic intervention. Our diagnosis was brain infarction localized unilaterally in the right paramedian thalamo-peduncular region. Anticoagulant therapy was initiated. Discussion. Monocular downbeat nystagmus is extremely rare, and the responsible lesion has not been clarified. In the present case, the responsible site of infarction was the paramedian thalamo-peduncular region, which is supplied by the superior mesencephalic and posterior thalamo-subthalamic arteries. Since both of these arteries branch from the same artery, namely the basilar artery, it is plausible that the infarctions found in the midbrain and thalamus occurred simultaneously, and that occlusions in these arteries would be attributable to a common mechanism. Paramedian thalamo-peduncular infarction is typified by clinical variations reflecting the topography and extent of ischemic damage, with or without monocular downbeat nystagmus. To date, 2 other cases have been reported in which oculomotor nerve palsy in one eye was associated with downbeat nystagmus in the other eye. As in our patient, the infarctions were unilateral and limited to the paramedian thalamo-peduncular region. Bilateral downbeat nystagmus is generally associated with a lesion in the cerebellum and has also been reported to result from an infarction in the midbrain. Monocular downbeat nystagmus has been attributed to dysfunction of the ipsilateral brachium conjunctivum. Curiously, however, in our patient as well as in the 2 cases reported by Jacob, monocular downbeat nystagmus occurred in the eye contralateral to the midbrain lesion. The possibility cannot be ruled out that, in this case, the monocular downbeat nystagmus was caused by the unilateral lesions found in the central nervous system. However, taking into account all the patient's symptoms and clinical findings, we believe that bilateral downbeat nystagmus was present, but masked by a concomitant pathologic disturbance. Given that oculomotor nerve palsy was present in the opposite eye, we postulate that the present case, as well as the two cases reported by Jacob, can be explained as bilateral downbeat nystagmus manifesting as monocular downbeat nystagmus. A small infarction in the brainstem is often undetectable by CT scan, making clinical manifestation all the more important in establishing a diagnosis. For example, in a patient with unilateral oculomotor nerve palsy and contralateral downbeat nystagmus, a paramedian thalamopeduncular infarction is suspected even if CT scan is normal. A number of syndromes are known to involve the cranial nerves and/or brainstem, such as Weber's syndrome, Maillard-Gubler syndrome, Wallenberg syndrome, Foster-Kennedy's syndrome, Vernet's syndrome, and Collet-Sicard syndrome. Knowing the manifestations of these various syndromes can be helpful in determining the site of the lesion.